As pediatricians get better and better at saving children that might have not survived their illness, we have a lot more long-term morbidity that we're facing with these kids. We get, as humans, our lifetime supply of nephrons at the time that we're born full term. And a nephron is the individual filtering unit that allows our kidney to do all of the amazing stuff that it does. And when you have significant illness, when you get exposed to nephrotoxic drugs, those nephrons can die off. That if you don't make it through your whole gestation, that if you live in an incubator for part of it, you're living in an incubator during the time that your kidney is making its lifetime supply of nephrons. And also, to keep those children alive, to keep those babies alive, we use medicines that we would never use otherwise because they are pretty kidney toxic. But they keep them alive, and so that's the hard part, is saving an infant and thinking about its long-term risk of chronic kidney disease. We have two different roles, I would say, as a pediatric nephrologist. The first one is at the bedside when the baby is first born, and if that child develops acute kidney injury. So we're there to help with the management of the acute kidney injury, because we do know that kids that have acute kidney injury go on to potentially are at risk for chronic kidney disease. We know that from adult studies, we know that from pediatric studies. The literature is not out there quite yet on the preemie babies. And part of that reason is because the micro-preemies, the smallest infants, have only been around for about 30 years. The neonatal medicine got revolutionized when, it changed its trajectory a great deal when the development of surfactant came available. And so surfactant has been consistently used since the 1980s. So those kids are only 30 years old. And so if you get your whole lifetime supply of nephrons at birth, it's supposed to last you your whole life. And we don't know the long-term ramifications of being born prematurely at this point yet, and we haven't studied it yet. And then my second job is to follow those kids up, because we don't know who is going to actually develop chronic kidney disease. I don't know how many nephrons that child was genetically designed to have, or how many they lost during their injury. I don't know how many nephrons you have or how many nephrons I have. We have bulk scores of measurement for kidney function. So it takes all of those nephrons together, and we can know how many or how well the kidney is working. And what we're working on in our NICU in particularly is getting that information transmitted from what happened during that 3-month stay in the NICU to a pediatrician, because that pediatrician needs to have that information to make decisions on a regular basis. Number one, if they know that the child had kidney injury or maybe got a large burden of nephrotoxins during their hospitalization, they might do something a little more preemptive, whereas a child that was totally normal and full term, they may not. No, I don't think that all pediatricians know the risk factors for chronic kidney disease, and that is my job to transmit that information. Because I get a decent number of phone calls from pediatricians when they find a child that has chronic kidney disease during their childhood, and it's usually a, wow, I didn't even think that that child was at risk for kidney disease. And you go back in their history and they were born as a micropreemie, or they had, some event, or even the kids that have other medical problems, even those children are at risk for chronic kidney disease. And I'm not sure that the general pediatrician knows that.